Welcome back to the Hospice Intelligence Channel. I'm Dr. Brian Haas, National Medical Director and founder of Hospice Intelligence. If you're a hospice nurse, physician, or administrator, I need your attention for the next 12 minutes. What I'm about to share could be the difference between passing your next Medicare audit and facing hundreds of thousands of dollars in denials. Medicare spent over $27 billion on hospice care in 2024. And with an improper payment rate hovering around 12%, auditors are coming. Not maybe, not eventually, they're already here. Today, we're diving deep into the 7 most common documentation pitfalls that get cancer patients' claims denied. And more importantly, how real-time auditing technology is revolutionizing compliance for forward-thinking agencies. First, let's talk about what's really happening out there. You've got TPE audits, which are targeted probe and education. You've got SMRC reviews, or supplemental medical review contractors. You've got UPICs, United Program Integrity Contractors. It's the alphabet soup, and they're all looking at your documentation. Now, here's the kicker. The #1 reason for hospice claim denials across all diagnoses: documentation that doesn't support a 6-month or less terminal prognosis. Now, for cancer patients specifically, this gets even more complicated because you're dealing with disease progression, treatment responses, functional decline, and those detailed LCD requirements. And the consequences? They're not just slaps on the wrist. We're talking claim denials, massive repayment demands, corrective action plans, and in extreme cases, exclusion from Medicare participation entirely. So yeah, this matters a lot. Now, let's break down what Medicare actually requires for cancer patients. This is where most agencies start getting into trouble. Not because they don't care, but because these requirements are specific and nuanced. For a cancer patient to qualify under LCD guidelines, you need all of these mandatory requirements. #1, clinical findings of widespread, aggressive, or progressive malignancy. Not just patient has cancer. You need to show it's advancing. #2, palliative performance scale of 70% or less. And not just the number, you need the functional description that matches it. #3, dependence on assistance for 2 or more activities of daily living. Again, specificity matters. #4, either pathology evidence of metastasis or documented disease progression despite undergoing treatment. Now, then you've got your supporting documentation. These could be things like hypercalcemia over 12, weight loss exceeding 5% in 3 months, recurrent disease after treatment, advanced disease symptoms like malignant ascites. Now, this isn't just about checking boxes. It's about painting a complete clinical picture that tells the patient's story and justifies the terminal prognosis. All right, here are the 7 most common pitfalls that torpedo cancer documentation. Now, I see these every single day. Pitfall #1, generic physician narratives. So check this out. This is an actual narrative from a medical review. Case discussed at IDT, care and meds approved. Really? That's it? That's the whole narrative? And guess what? It got denied. Medicare requires that the certifying physician compose a brief narrative explanation of clinical findings that supports a life expectancy of 6 months or less. So here's what that should look like. 78-year-old male with stage 4 lung cancer with documented liver and bone metastases. He completed 6 cycles of FOLFOX chemotherapy. A PET scan from March 15th shows progression and new pulmonary lesions. Patient declined further treatment. Choosing comfort measures. The PPS score is 50% because he's bedbound, requires total assistance with all ADLs, his weight loss of 18 pounds over the past 2 months, representing 12% body loss, oxygen dependent at 6 liters, morphine every 2 hours for bone pain, and dyspnea. Now, do you see the difference? This one was patient specific, had objective data, showed a timeline, functional status. Now that's what passes a review. Pitfall #2. No documentation of decline. Auditors are specifically looking for decline. Medicare wants to see that things are getting worse, not staying static. But here's what I see. The patient has metastatic cancer, PPS 60%. Okay, well, what was it last month? Last week? At admission? You need to establish baselines at admission and track changes. The patient admitted 6 weeks ago at a PPS of 70%, ambulatory with assistance. Today, the PPS is 50%, bed bound. Weighted admission is 185 pounds. Today, 168 pounds, a 9% loss. You have to show the trajectory, not just the snapshot. That's what proves terminal decline. All right, pitfall number 3, incomplete PPS and ADL documentation. So a PPS score of 70% or less is mandatory for cancer patients under the LCD. But writing a PPS of 50% without explanation, that's really not enough either. The right way, PPS 30%. Patient is bedbound 100% of the time, requires total assistance for all transfers, unable to perform any self-care activities including feeding and toileting, conscious but only taking sips of water, no solid food intake for the past week. The number means nothing without the clinical picture. And for ADLs, don't just say needs assistance. We need to specify bathing, dressing, toileting, transferring, continence, feeding, which ones, and how much help does the patient require. Pitfall number 4, treatment failure is not connected. So for cancer patients, the LCD says you need to show either the patient refusing treatment or continues to decline despite treatment. But documentation often misses this completely. Often they'll say patient has metastatic lung cancer. Well, okay, but what treatment did they try? When? What were the results? So if we instead say patient completed 6 cycles of carboplatin, Paxlotel ending February of 2025, follow-up CT scan on March 1st shows progression, new liver lesions, and increased tumor burden in the lungs. The oncologist is recommending a second-line therapy. Patient declined, electing hospice care. Connect the dots. Treatment, response, decision. That's the story that the auditors need to see. Pitfall number 5, ignored comorbidities. Cancer rarely exists alone. Your 75-year-old with pancreatic cancer probably also has COPD, CHF, diabetes, maybe even some renal insufficiency. Documentation focuses only on the cancer sometimes. We need to broaden that to specifically mention comorbidities as supporting factors. Each one should be documented with current status, severity, symptoms, and how it impacts overall prognosis. Patient also has CKD stage 3 with creatinine of 2.8, COPD on home oxygen, 3 liters continuous, and CHF with an EF of only 25%. They've had multiple hospitalizations in the past 3 months for fluid overload. These are not side notes. They're part of why this patient has a 6-month prognosis. Now, pitfall number 6, the face-to-face visit. Starting with the 3rd benefit period, you must have a face-to-face visit by a physician or a nurse practitioner and documentation that explains how those findings support continued eligibility. So common failures are maybe it's missing entirely or it's too generic. The nurse practitioner comments, saw a patient, continues to decline, but there's no connection to that 6-month prognosis. Or it could be the wrong timing. It's outside the allowed window. A proper example looks something like this. A face-to-face visit conducted April 15th, 2025. Patient significantly declined since last recertification. Now bedbound with a PPS of 40%, which was decreased from 60% prior. New onset confusion, diminished breath sounds bilaterally. Oxygen requirements increased to 6 liters from 4 liters. Based on rapid functional decline and advancing disease, the patient continues to meet criteria for a prognosis of 6 months or less. Pitfall number 7, missing objective data. Last one, but it can be huge. Vague impressions versus hard data. So patient appears weaker. Well, let's compare that against patient has lost 15 pounds over the past month, 8% of their body weight. Current weight 175 pounds from admission weight of 190 pounds. Albumin is decreased from 3.2 to 2.3. Or we have increased pain. Well, that's not very specific. We could instead say Pain level increased from 4 to 10 at admission to 8 to 10 currently, requiring morphine dose escalation from 15 milligrams Q6 hours to 30 milligrams Q4 hours over the past 2 weeks. Your clinical impression matters, but back it up with numbers, dates, measurements, and lab values. That's what makes documentation defensible in an audit. Okay, so those are the 7 pitfalls. Now here's the problem with traditional compliance. You train your staff. They document. Weeks or months later, someone does a chart audit. They find problems. By then, the note's already signed, the claim's already submitted, and if there's a denial, you're fighting uphill. This is reactive compliance. You're discovering problems after the damage is done. But what if you could catch these issues in real time, as the nurse is writing the note? That's what intelligent auditing technology does. It reviews documentation as it's being created, using the same LCD criteria that Medicare auditors will use. So imagine a nurse is documenting a visit for her 72-year-old cancer patient. She writes the note and the system immediately flags. No PPS score documented, no comorbid conditions noted. Medicare requires weight loss to be presented as a percentage. You may have the data incorrectly, but if you didn't do the math, you didn't comply. So Hospice Intelligence does it for you. The nurse can fix these issues right now while the visit is fresh in her mind, before the note is signed, before it ever goes to billing. The documentation becomes more complete, more compliant, more defensible, not through extra work, but through real-time guidance. Now, think about what this means for your agency. You prevent denials before they happen, instead of appealing them after the fact. You educate clinicians continuously through immediate, contextual feedback, not through quarterly training sessions they forget by next week. You reduce administrative burden because you're catching issues once in real time, not requiring multiple chart reviews. You protect revenue by ensuring documentation supports medical necessity from day one. And you build audit readiness into every single note. So when that audit letter arrives, you're not panicking. For cancer patients especially, with their complex disease trajectories and detailed LCD requirements, this real-time support ensures the clinical story is told completely and compellingly. Look, Medicare's program intensity efforts aren't slowing down. They're ramping up. The question isn't if your agency will face an audit, it's when. The agencies that will thrive are those that embed compliance into daily workflows instead of treating it as a separate, after-the-fact function. Hospice Intelligence offers this embedded, real-time auditing capability. Think of it as a virtual compliance officer reviewing every note, guiding every clinician, ensuring your documentation meets LCD standards before it's ever submitted for payment. The 7 pitfalls we covered today, they're all preventable with the right technology and processes. Thanks so much. We'll see you next week.